Good morning and welcome to my channel. I am Baby Agbo Jaswi by name, and today I will be discussing on a very important topic known as pharmacodynamics. What is pharmacodynamics? In one sentence, pharmacodynamics simply means the effect of drug on the body. If you should take drug, what effect will that drug produce in your body? What is the mechanism in which that drug produces that effect? What are the receptors necessary for that effect to take place? These are the things that pharmacodynamics actually entails of. To begin, let's talk briefly on the mechanism of action of drugs. Different drugs has different mechanism of actions. Some drugs act through physical mechanism, some act through chemical mechanism, and others act through what we refer to as enzymatic mechanism. Talking about physical mechanism, what comes to mind should be osmotic diuretics. What's a diuretics? A diuretic is a drug or a compound that you take to increase the flow or excretion of water. So when somebody take a diuretic, the person excretes a lot of water, urinates a lot of water, and that process is called diuresis. So diuretic is the molecule or the drug taken to cause diuresis. Now, it is important to know that when you talk about osmotic diuretics, they are compounds or drugs that drag water with them. Whenever they are being excreted, they drag water with them. So when they are excreted in urine, water go along with them. The person excretes a lot of water when those compounds are taken because they drag water with them. Wherever they are going, water go with them. That's the physical mechanism of action. Example of this osmotic diuretics. A mnemonic can help you remember that Manchester United is good. That may not be true now, but there was a time in which Manchester United was actually good. So Manchester there means monitor, United means urea, it means isosobide, then good means glycerine, glycerine, glycerine. These are example of what? Osmotic diuretics. They drag water, they drag fluid. When you are excreting them, water go with them. Physical mechanism of action. There are some drugs that act through chemical mechanism of actions. These drugs that act through chemical mechanism of action, what do? They actually react. They react with what they are acting with. What comes to mind when you are thinking about chemical mechanism of action? You think about magnesium trisiliciate. For patients with gastric ulcer, a lot of gastrin or gastric juice, which is acidic, is majorly produced in the stomach. This can cause pain to these patients. To reduce this pain, you may give magnesium trisiliciate, which is like a base, to neutralize the acidic content of the stomach. Remember, neutralization reaction is an example of what now? A chemical reaction. So these drugs like magnesium trisiliciate acts using chemical mechanism. Some drugs also act through enzymatic mechanism. They can either stimulate enzyme, they can inhibit enzyme, they can do this through competitive, non-competitive, irreversible inhibition. All of them are enzymatic mechanism of action. Next, we have to know what we refer to now as a receptor. As we move on, we have to know about a receptor. Under pharmacodynamics, you should know about a receptor. What is a receptor? A receptor is like the target molecule for a drug to elicit its action. So for a drug to elicit its action, it has to bind to something. That compound, that molecule it binds to, that target component for a drug that a drug have to bind to in order to elicit its action is what we refer to as a receptor. It's very important to know things about these receptors because the receptors in our body is diverse. A particular drug cannot bind to all type of receptors. You get? So receptors can actually accept some component or some drugs, while other drugs does not interact with them. That's what we refer to as affinity. So for a drug to bind to a receptor, it must have an affinity for it. So though there are many receptors in the body, they don't accept or bind to all drugs. They only bind to a drug that has an affinity for it. Do you get? So that is one feature of a drug in order to bind to a particular receptor. Now, another important feature is what we refer to as intrinsic activity. What's intrinsic activity? After a drug has bind to a receptor, it stimulates that receptor so that it can produce its effects. The ability of a drug to bind to a receptor and stimulate it and excite it to produce its effect is what we refer to as intrinsic activity. So there's a difference between affinity and intrinsic activity. Affinity means that force or that binding power that a drug have for a receptor, the ability to bind to it. That's just it. The ability to bind to. However, after binding, there's an ability of the drug to stimulate the receptor so that it can produce an effect. The ability of a drug to stimulate a receptor to produce its effect is what we refer to as intrinsic activity. Intrinsic activity can move from 1 to -1. A drug that has intrinsic activity of 1 means when this drug binds to the receptor, it stimulates it to the maximal extent. A drug that has an intrinsic activity of between 1 and 0, it means that drug binds to a receptor, it stimulates it, but not to its maximum extent. A drug that has intrinsic activity of 0 binds to a receptor but does not stimulate it. It does not stimulate it at all. It just fills the space. But a drug that have an intrinsic activity of -1 binds to a receptor and brings the opposite effect, the inverse effects of that receptor. When I give an example, it will become very clear. There's what we refer to as a full agonist. A full agonist are full agonists are drugs or compounds that binds to a receptor to stimulate it maximally. So you can say full agonists have an intrinsic activity of 1 or +1. An example of full agonist is what we have where you have acetylcholine, carbachol. The example of full agonists at muscarinic receptors. They bind to muscarinic receptor and they stimulate it to its maximal extent. Also, we can have acetylcholine binding to beta adrenal receptor. Acetylcholine binds to beta adrenal receptor and stimulates it to the maximal extent. That's example of a full agonist. There's what we refer to as partial agonists. Partial agonists are drugs or compounds that binds to a receptor and stimulates it, but not to its maximal extent. So we can say partial agonists have an intrinsic activity of between 1 and 0. An example of partial agonist is pindolol. Pindolol binds to beta adrenoceptor but does not stimulate that receptor to its maximum extent. A drug that binds to a receptor and just fill the space, but it does not actually bring about stimulation to produce its effect is what we refer to as an antagonist. An example of such antagonist is where you have something like atropine, where you have things like scopolamine. These drugs bind to muscarinic receptors. They don't stimulate it, they just fill the space. They just fill the space so that full agonists cannot bind because they are just occupying that space. Then we also have what we refer to as an inverse agonist. An inverse agonist binds to a receptor and produce its opposite effect. If the receptor generally, if a drug binds to it, it's supposed to stimulate it to produce one effect. Once an inverse agonist binds to it, it will produce the opposite effect of that receptor. An example of this is beta-carboline that actually attached to benzodiazepine receptor. It produces the opposite effects that the receptor is supposed to produce. So it has an intrinsic activity of -1. So full agonist, intrinsic activity of +1. Partial agonist, intrinsic activity between +1 and 0. Antagonist has generally intrinsic activity of 0. Then inverse agonist has intrinsic activity of -1. It's very important you remember these important points. Let's now talk about the different type of antagonism that we may have. Different type of antagonism we may have. Remember, when you have an agonist, it favors. Antagonist does not want things to move in the direction of the agonist. Generally, if you have a muscle, remember when you have a muscle called the bicep muscle here, it flexes. The antagonistic muscle to the bicep is the tricep that will help to extend. You get it, does not want flexion to take place. There are different types of antagonism. There's what we refer to as physical antagonism. Physical antagonism, what comes to mind should be alkaloids, and activated charcoal. When somebody takes alkaloid, this is like a poison in excess. Excessive alkaloid can serve as a poison, or you can give the person activated charcoal. What will activated charcoal do? Activated charcoal simply binds to the alkaloid and prevents them from being absorbed. So it prevents them from entering into the system, from being absorbed by the intestine. What it just does is that it binds to it. So when activated charcoal binds to alkaloid cannot be absorbed. So it prevents that poison toxicity. Do you get at all? So we can simply say that that's an example of a physical antagonism, where a compound binds to another, preventing its absorption. And we've given an example: activated charcoal binds to alkaloid, preventing its absorption. There's also what we refer to as chemical antagonism. In chemical antagonism, the compound binds to the compound that it wants to, the other compound it wants to prevent its action from occurring, and then it reacts with it. So it's between physical and chemical. Physical just binds to it, but it does not react with it. It prevents its absorption. But chemical antagonism, in chemical antagonism, the antagonist binds to the molecule and reacts with it. It reacts with it. Let's give an example. You have chelators. For example, if you have iron toxicity, somebody who takes too much amount of iron, maybe orally, mistakenly, maybe a child, you can give dysferosamine. Dysferosamine is a chelator. It reacts with those ions so that it will not be absorbed, so that this person will not have that toxicity within the system. It chelates. That's the words to use. The right word to use is it chelates. So dysferosamine chelates iron, and it's an example of a chemical antagonism. There's also what we refer to as a physiological antagonism. What's physiologic antagonism? When we talk about this type of antagonism, take your mind to the bronchioles and the bronchi. Now, within the bronchioles, which is simply the airway where air passes through to go into the lungs, there are some receptors there. There's what we refer to as the receptors for adrenaline. That's adrenoceptors. Whenever adrenaline binds to adrenoceptors within this airway passage, within this bronchi and bronchioles, it helps to dilate the airway. But whenever there is histamine binding to maybe H1 receptor, it helps to constrict that airway. Note that in allergic reactions like asthma, histamine is released from mast cells. And once this histamine is released, it may go to the bronchi, acts on the H1 receptor, that's the histamine receptor there, to cause bronchoconstriction, making the airway narrow. No wonder the person start to gasp for air. When you give this person Ventolin, you give them the normal drugs, salbutamol, those drugs that you give to relieve those who have asthma, they are they are dilators, bronchodilators. They go to the bronchos and the bronchioles and cause dilation. How do they do this? They bind to adrenoceptor. Now, you can see that this is an example of a physiologic antagonism in which the drug does not bind to the same receptor. They bind to another receptor in the same location and produce an opposite effect. So histamine binds to a receptor in the bronchiole to cause constriction, whereas adrenaline or non-adrenaline binds to another receptor to cause the opposite effect, which is dilation. So the effect of adrenaline and histamine within the bronchioles is an example of a physiological antagonism. They bind to different receptors. However, when you have a compound or a drug binding to the same receptor, that will be a pharmacological antagonism. Also, pharmacological antagonism is a drug preventing the action of another by binding to its receptor. For example, we know that adrenoceptors are stimulated by maybe adrenaline, non-adrenaline, or some of their other compounds to cause dilation of bronchiole. Now imagine there you now give somebody, let's say, beta blockers. That's a compound that can block that receptor. It blocks the beta adrenoceptor. When the person now take epinephrine or adrenaline, it cannot act on that same receptor because it has been blocked. Therefore, the opposite action will not take place. So somebody that has asthma, and you are giving the person beta blocker. When you give the person beta blocker, there's no way epinephrine or no epinephrine, that's adrenaline or no adrenaline, can still act on that receptor because it has been blocked. You get? So that's an example of pharmacological antagonism, where a compound or a drug binds to the same receptor that another compound or drugs want to bind to in order to prevent its effects. Pharmacological antagonism. So we've seen the type of antagonism that we have. Yes, physical antagonism. What comes to mind in physical antagonism? Remember, activated charcoal and alkaloid. Chemical antagonism. What comes to mind? Dysferoxamine with a chelator of iron. Physiological antagonism, where compounds bind to different receptors to produce opposite effects. And then lastly, pharmacological antagonism, where compound binds to the same receptor so that the other compound cannot bind to it, preventing its effects. What are the classification of receptors that we have? There are different classifications, different classes of receptors we have. We have G protein couple receptors. G protein couple receptors. What comes to mind there? You just need to know that G protein couple receptors, they are majorly used by water-soluble hormones. Yes, water-soluble hormones. Since they cannot pass through the what now, they cannot pass through the cell membrane. They majorly use G protein couple receptors. It's a transmembrane receptor. It's also called 7-transmembrane serpentine receptor. It has GDP attached to alpha, beta, and gamma. But when it's stimulated, it forms GTP alpha, then beta and gamma moves on their own. They act by activating second messenger, by using second messenger. Example of second messenger, CAMP, you can remember that perfectly. IPT, that's inositol triphosphate. DAG, these are example of second messenger. Another group of another group of receptor apart from G protein couple receptors, ionotropic receptors, where the receptors are located within the ion pores. The ion gated channels, you see the receptors located there. It's a fast mechanism. They have fast mechanism of action. And what comes to mind there should be something like serotonin, glutamates. They are using this mechanism. Then we also have what we refer to as enzymatic receptors. Enzymatic receptors, they have and they they have an extracellular and an intracellular site. So when the drug binds to the extracellular site, it causes what we refer to as activation of tyrosine kinase within the intracellular sites, and that can cause JAK-STAT pathway, and the reactions takes place. Things like prolactin, they are using this mechanism. Growth hormone, they use these type of receptors. Then intracellular receptors, they are very slow. They have very slow mechanism. Fat soluble hormones actually use this mechanism. Some receptors are located in the cytoplasm, intracellular receptors. Some are also located in the nucleus, the intracellular receptors. Example of hormones that act using the receptors in the cytoplasm is where you have glucocorticoids, just like cortisol, mineralocorticoids, like aldosterone, even vitamin D. Then when you talk about the compounds or hormones that act receptors located in the nucleus, you think about T3, tyrosine, T4, triiodothyronine, progesterone, estrogen. They all act using this mechanism. These are the classification of receptors. So far, we've been able to talk about pharmacodynamics to some extent. I think in my next video, I finish pharmacodynamics. We've been able to talk on one, we've seen the definition of pharmacodynamics. Two, we know the type of antagonism that we have. Three, we know what's intrinsic activity, what's affinity, that receptor actually possess, classification of receptor, so on and so forth. Let's put this important information at the back of your heart as we continue to learn more in pharmacology. Please subscribe to my channel so you'll be seeing many videos like these that I'll be producing every week. Thank you very much.